Today's lecture is on infectious disease. Infectious disease, have they been conquered? In the past it was thought so. However, this was premature. With the 21st century, there has been an increase in the resurgence of infectious disease, especially those of viral origin. Between 1973 and 2003, there have been 36 new infectious organisms identified. Antibiotic resistance is a concern. We have seen the development of antibiotic resistance following the discovery of penicillin in 1928. Although penicillin has been a miraculous medication that's helped treat bacterial infections, unfortunately the bacteria are able to mutate. They're able to survive despite being exposed to these antibiotics, which has caused the need for the development of newer antibiotics. Most of our antibiotics in current use were discovered in the 1940s to 1950s, and they only are directed at a few very specific aspects of bacterial physiology, which include cell wall biosynthesis, DNA, and proteins. During the past 40 years, only 2 new chemical classes have been developed, and that is one of the reasons for widespread resistance among pathogens is the fact that there is a limited choice in antibiotics because those antibiotics that are in existence only manipulate a very narrow range of bacterial functions. We have unfortunately also seen the resurgence of some previously thought to be eradicated pathogens, and we are now seeing things such as multi-drug resistant tuberculosis and tuberculosis that seems to be almost completely resistant to our standard treatments that in the past have been successful. These multi-drug resistance cause increasing numbers of bacterial infections in hospitals, and also most of the organisms that have had attention toward them to treat have been our gram-positive organisms such as our MRSA. Virtually no new development has been made on our gram-negative pathogens. Surgical site infections. As anesthesia providers, this is something we're going to be very concerned with, and it is a very common cause of healthcare related infections. The definition is that it is an infection that occurs near or at the site within 30 days of the procedure or within 1 year if prosthetic material has been implanted into the patient. This table has been taken from your text, and it defines the types of surgical site infections, the time course that must be present to define that specific type of infection, and the criteria. And it's to be noted that at least one of the criterion needs to be present to be defined as a surgical site infection. You can see there's superficial, deep incisional, and organ space. The superficial, at least one of the criteria of superficial pus drainage should be present. Organisms cultured at a superficial tissue site or from fluid, and there's signs and symptoms of infection such as those things you would expect as pain, redness, swelling, or heat. Deep incisional would be deep pus drainage. Also, dehiscence or wound had to be reopened by the surgeon. And the reasons they would have to be reopened would be for a temperature greater than 38 degrees Celsius, pain and or tenderness, or the presence of an abscess. The organ space surgical site infection involves pus or drainage from the organ or the organ space. Organisms cultured from an aseptically obtained specimen of fluid or tissue in the organ space, or an abscess involving the organ or the organ space. Again, clinical criteria. You would need to have one or more of these criterion present. and that would be purulent exudate from the surgical site, positive fluid culture obtained from a surgical site, surgeon's diagnosis of infection, or surgical site requiring reopening, and for those reasons we discussed previously. But signs and symptoms that could also be present are localized inflammation, evidence of poor wound healing, or systemic features of an infection such as fever or generalized malaise. This figure is demonstrating where you would see the various types of surgical site infections. The organ space infections only count for about 1/3 of all surgical site infections, but they are associated with a higher mortality because they're responsible for 90% of the deaths related to surgical site infections. The superficial involves the skin and subcutaneous tissue, and the deep would obviously involve the fascial and muscle. With the organ or tissue space, again, would be infections of the organ or the space around the organs. This table is showing you the difference between the wound classification and the expected infection rates associated. So we begin with clean wounds, and clean wounds are basically unaffected operative wounds in which there is no inflammation and the wound is closed primarily. By definition, you would not enter a viscous site such as your respiratory, your GI tract, your genital or urinary tract would not be entered in this clean procedure. Clean contaminated wounds are operative wounds in which the viscous is entered, but it's entered under controlled conditions and without unusual contamination. Contaminated wounds are open, fresh, accidental wounds. Operations where you have major breaks in sterile technique or gross spillage from a viscous. Wounds in which acute or purulent inflammation was encountered would also be classified as contaminated. And then dirty wounds are your old traumatic wounds with devitalized tissue, foreign bodies, fecal contamination, or wounds that involve existing clinical infection or a perforated viscous. There, in 2002, there was a development of the SIP project, which is Surgical Infection Prevention Project. The measures included looking at the proportion of patients who received antibiotics within 1 hour prior to incision, and that would give 2 hours for antibiotics that would require a longer time to infuse, such as vancomycin or fluoroquinolones. The proportion of those who received antibiotic therapy consistent with guidelines, and the proportion of those who prophylactic antibiotic was discontinued within 24 hours. So those were the measures that were being looked at. Although it's important to try to avoid surgical site infections and to follow the guidelines, one thing we do have to look at is certain risk factors exist in the patients for the development of these types of infections, and also certain microbial type factors are present that could result in surgical site infections. Patient-related factors are those things you would think about that would make somebody be at higher risk for any type of infection, and that is the very young or the very old, if they have an issue with immunocompromise anyway, diabetes, or those on some sort of immunosuppressive therapies, such as our corticosteroids. Smokers are at higher risk, those who are obese, those with coexisting infections, those with poor nutritional status, and our patients who have an ASA score of greater than 2. Also, the microbial factors that can be present are the fact that the microbes can actually produce enzymes. They may also possess a polysaccharide capsule and the ability to bind to fibronectin in blood clots. These mechanisms um, these mechanisms will help the microorganisms exploit the weakened host defenses and help to initiate an infection. Biofilm is also very important, especially in prosthetic materials. Um, so they're capable of actually developing this biofilm. They can also, the colase negative staphylococci can produce a glycocalyx and associated components called slime, and this physically shields the bacteria from phagocytosis or inhibits the antimicrobial agents from binding and actually penetrating the bacteria. Wound-related factors, things that would increase the risk for a surgical site infection, is the presence of devitalized tissue. If we have dead space, that's a breeding ground for the infection. If there's hematoma, if it was a contaminated surgery, or the presence of foreign material such as sutures or mesh, that the presence of those type things will reduce the number of organisms required to induce a surgical site infection. Goals of therapy would to be reduce the number of microorganisms that are at the surgical site, to reduce the ability for them to actually develop into an infection or produce infection. One thing is to follow our hand hygiene guidelines, and we talked about those a little bit in the boot camp lecture. To make sure we have the appropriate barrier devices. Make sure that we are not only administering in the appropriate amount of time, but we actually have the appropriate antimicrobial for the various types of procedures. Maintenance normothermia for the patient. And if we think we're going to enter, or we could potentially enter into the colon, performing a pre-op colon cleanse to clear fecal matter from the colon. Another thing particularly important when we talk about our total joints is to decrease OR traffic. So we shouldn't be walking in and out, and it should not be a lot of unnecessary people in the room. Preoperatively, some things that can be done for the patient, even though there's no general consensus on colonization, we need to kind of gear that toward the individual. Sometimes it's appropriate, or it would be appropriate for surgical patients who are known to be nasal carriers of MRSA, especially if there's high risk of them developing the surgical site infection. Again, relevant patients may be those who are immunocompromised, if they're undergoing cardiac surgery, or if they're having an implanted foreign device. The treatment is just topical Bactroban to the nares. Also, hair removal. Hair removal should not be removed with razors. It should be removed with an electric razor, because that causes less with clippers, because it causes less injury, and the actual razors themselves can actually cause some gross skin cuts when seen by a scanning electron microscope. So that's important. Also, the lowest rates of surgical site infections were seen when the hair was removed just prior to the surgical incision, rather than removing it maybe a day before. Making sure they have the appropriate skin antisepsis. And we know the body has bacteria on it. It is recommended that patient and or family members should have some preoperative education on when to use a chlorhexidine product prior to surgery. Usually this is recommended once a day for 3 days. If they're allergic to chlorhexidine, then they can use an antibacterial soap such as Dial, and that will decrease the amount of bacteria that is on the skin. Any patient with active infection should be treated aggressively prior to surgery, and whenever possible, the surgery should be postponed until that's resolved. Also, cessation of smoking for 4 to 8 weeks prior to any orthopedic surgery will decrease the risk of wound-related complications. Intraoperatively, things we can do is make sure we're administering the correct prophylactic antibiotic, and we want to make sure that the antibiotic is infused at least at the same time or 1 hour prior to incision, and that we are following the appropriate guidelines for the surgical case. And this 1 hour, remember, is we exempt vancomycin and our fluoroquinolones. You want to stop your prophylactic antibiotics at 24 hours post-operatively, um, or if it's cardiac surgery, this can continue for 48 hours. Your dose for your antibiotics would need to be increased based on the size of your patient, so it's important to make sure they have the appropriate dosing. You need to redose your antibiotics when surgical procedures are greater than 3 hours, and this is from the CDC guidelines. Again, administer antibiotics appropriate for local resistant patterns. So if you're at a facility that has a particular type of bacterial infection that seems to be prevalent, and they're resistant to a particular antibiotic, it would be imperative that you would administer the appropriate antibiotic for that resistant pattern. You want to follow your American Heart Association guidelines for infective endocarditis, and we have covered those. If you need to review them, remember that we covered that in the vascular section. We also covered it in endocarditis itself, so please review those. Adhere to procedure-specific antibiotic recommendations, which we have mentioned. And although this is controversial for universal adoption, it is recommended to decrease surgical site infection is to maintain your FiO2 at least 50%. Now, there's a lot of reasons this isn't just completely adopted by everyone because this is thought to increase the risk of atelectasis postoperatively. So you won't see this, although it is recommended by the CDC, just simply to decrease the risk of infection. Glucose, you want to make sure you're keeping the blood glucose level in normal range. High blood glucose levels inhibit white blood cell function and also provide a more favorable environment for bacterial growth. Another thing to think about is postoperative pain management may help to increase postoperative oxygen levels, and also hypocapnia will increase vasoconstriction, so it's important that your patient's pain is under control so that they can breathe and not splint and not hyperventilate. A quote from Joint Commission. And this quote is to show how important what we do and that we are responsible for administering the antibiotics appropriately. And the quote is, anesthesia practitioners became responsible for providing the prophylactic antibiotic within 1 hour prior to the surgical incision. Although staff nurses have historically administered the prophylactic antibiotic, the evidence clearly indicates the antibiotic must be administered within the 1 hour prior to surgical incision, which in most hospitals could not be done on time by the staff nurses. Anesthesiology has been identified as the discipline to administer the prophylactic antibiotic based on the workflow prior to surgical incision. So, based on this, which we already know, this is one of our responsibilities in the operating room. But just to clarify that we are indeed the ones that if the antibiotic doesn't or isn't administered appropriately, the responsibility falls on us. Surgical site infections, most times a first generation cephalosporin is appropriate for, again, many types of our surgeries, and there's also a very low incidence of side effects with these type of medications. However, if you enter the bowel You would need to cover for a gram-negative organism and for procedures involving large bowel in the female genital tract. You would also need to cover against anaerobic organisms. These next few slides are talking about the types of surgeries and the types of medications that are appropriate. I want you to know the recommended antimicrobials for specific surgeries. However, I do not want you to memorize the usual dose or redose interval. But again, it talks about the nature of the operation, common pathogens associated, and the recommended antimicrobial therapy. That's where I want your focus to be. Same holds true for this slide. Same for this slide. The same for this slide. And the same for this slide as well. And the same here. I don't want you to get overwhelmed because if you notice, most surgeries can be covered with cefazolin, which is our first generation cephalosporin. Again, I just want you to be familiar, and if you're going to enter into the bowel or the female genital tract, there are additional medications you would need to provide. And again, for the recommended antimicrobial cephalosporin covers, again, cardiac procedures as well. Again, I don't want you to get overwhelmed and thinking you have so much to memorize because, as you can see, most procedures can be accomplished effectively with cephalosporin. Another type of infection we need to worry about is bloodborne infections, and these are among the top 3 nosocomial infections. Central line catheters are a common cause, and catheter-related infections are common, they're costly, and potentially lethal, with mortality being from 12 to 25%. Patients will typically have nonspecific signs of infection with no obvious source. Occasionally they will have, if there's an indwelling catheter, they may have inflammation at the catheter site, and that would be obviously suggestive of a catheter-induced infection. And what we're looking for again is that there's no obvious source of the infection. So they don't have issues with their urine. They're not having purulent sputum. They don't have pus drainage. There's no wound inflammation. Again, diagnosis would be bacteremia, fungonemia in a patient with an intravenous catheter. They would have at least one blood culture positive for a recognized pathogen not related to a separate infection. They would have clinical manifestations of infection. And again, no other apparent source for the infection with the exception of the catheter. Again, blood stream infections are considered to be associated with the central line if the line was in use during the 48-hour period before the development of the bloodstream infection. The diagnosis, again, is more compelling if after the catheter's removal, the same organism that grew in the blood culture is also growing from the catheter tip. The best treatment for central venous catheter infections related to bloodstream infections is prevention. However, if infection is suspected, the source of the infection should be removed as soon as possible and a broad spectrum antimicrobial agent started, which again would be switched to a targeted treatment once the specific organism has been identified. CDC's recommendations for reducing central line infections includes 5 interventions, And these include hand washing prior to insertion with soap and water or prior to maintenance. To use full barrier protection, that's hat, mask, sterile gown, sterile area covering during central venous catheter insertion, cleaning the skin with chlorhexidine, avoiding femoral and peripheral arms if possible, and conducting routine daily inspection and removal of the catheter as soon as it is deemed unnecessary. Central venous catheters impregnated with antimicrobial or antiseptic agents will lower the infection rate, but costs and there's worry about resistance developing if they're widespread use. However, these are still indicated if you have a immunocompromised or very vulnerable patient. Transfusions actually increase the incidence of postoperative infections, and there's two proposed mechanisms. One is that there can be direct transmission of organisms, and that can result in infection of the recipient. And it's showed that bacterial contamination has emerged as the greatest residual source of transfusion related or transmitted disease, and it's 1 in 1,000 to 3,000 units of platelets are contaminated, which to me is terrifying. Also, there is an immunosuppressive quality to receiving blood. Even your own blood can result in natural killer cell inhibition and can result in immunosuppression. The best way to avoid these specific complications or these infectious related complications is to limit transfusion to when it's simply necessary, so to avoid or minimize their use. There are several postoperative management actions that can decrease the incidence of catheter-related bloodstream infections, and one of those is to remove the central line and pulmonary artery catheters as soon as possible, just as soon as they're deemed unnecessary, and also to avoid the unnecessary use of parenteral nutrition. Sepsis is a disorder that as nurses we should all be aware of. Obviously, with surgery and anesthesia, it should be postponed until sepsis is at least partially treated. That is unless we have to perform it due to emergency or until we treat until we perform the surgery, we're not treating the cause. So, for example, if we have a septic abscess, abscesses are always considered emergencies, infective endocarditis, bowel perforation, the patient's just going to continue to get worse unless we provide surgical treatment. Sepsis, as you know, is a life-threatening condition, and we have bacteria components such as endotoxin that can cause a wide range of pro-inflammatory issues. So endotoxin, through their action on neutrophils and macrophages, can cause these factors to actually turn on and produce a pro-inflammatory cytokines. As a result, the sepsis, there's a a systemic inflammatory response syndrome that occurs, and that's a similar response which occurs in the absence of infection. So we have a systemic inflammatory response is one of our nonspecific immune responses. Again, this can cause exaggerated activation of our complement system and coagulation cascade, and we can end up with widespread arterial vasodilatation, altered capillary permeability, which can result in acute organ dysfunction, and then septic shock is defined as severe with sepsis with hypotension, which is not reversed through fluid resuscitation. This image is just showing you the definition of what is infection, what is sepsis, what is severe sepsis, and what is septic shock. And you can see the estimated mortality associated with these various conditions. It would behoove you to know the definitions of each one of these disorders. Sepsis signs and symptoms will vary with the initial source of infection. And as we said, sepsis may result in multiple organ system failure. Again, the septic shock would refer to hemodynamic instability that may accompany sepsis along with perfusion abnormalities that may include but not limited to lactic acidosis, oliguria, or changes in mental status. Classically, we see hypotension, bounding pulses, and widening of our pulse pressure. Again, there are characteristic signs of high output cardiac failure and distributive shock, both of which may occur with sepsis. The diagnosis of the systemic inflammatory response syndrome requires the fulfillment of 2 or more of the following criteria, and you can see those listed. I would know those criteria. And again, the diagnosis of sepsis would be based on confirmation of being able to isolate a specific causative pathogen. Again, it would be important to identify that microbe to ensure that the antimicrobial therapy is targeted toward that organism. Specimens for culture should be sent from all possible sources where the organism growth is suspected. Again, blood, urine, and sputum at the bare minimum. Other sampling can be done on a need-to basis. So the goal is to start a broad spectrum treatment and then diagnose and be able to provide very targeted therapy. Treatment would be with the use of broad spectrum antimicrobial coverage and then supportive care of the failing organs. And again, the speed and appropriateness of therapy is in the initial hours can dramatically influence outcomes. In addition, like we said early, a goal-directed optimization that targets oxygen delivery and cardiac output can help improve outcomes. Again, the prognosis depends on some factors such as the virulence of the infecting pathogen, the stage in which the treatment was initiated, inflammatory response of the patient, the immune status of the patient, and the extent of end organ dysfunction that is present. Treatment algorithm. Again, the important characteristics for a patient with sepsis requiring surgery are whether the surgery can be postponed. Again, ideally, unless the surgery is necessary, this would occur until we at least treat the sepsis. A treatment algorithm for sepsis patients is listed and suggests a goal-directed therapy, and the goals would be to achieve a mean arterial pressure of greater than 65, to maintain a central venous pressure of 8 to 12, to have adequate urinary output, to have a normal pH, and to maintain a mixed venous oxygen saturation above 70%. The normal SVO2 is 75%, which indicates under normal conditions the tissue is extracting approximately 25% of the oxygen delivered. An increase or in VO2 or a decrease in arterial oxygen content is compensated by increasing cardiac output or tissue oxygen extraction. When the SVO2 is less than 30, the tissue oxygen balance is compromised and the patient will go into anaerobic metabolism. Here is the figure from your text that talks about the resuscitation and therapy that needs to be instituted. Intraoperative management of these patients is very challenging. Again, they have very limited physiological reserve, and they are very vulnerable to hypotension and hypoxia. You need to have invasive monitoring if possible. And again, that can be intra-arterial blood pressure, and central venous pressure is usually indicated. You want to have appropriate IV access to allow appropriate volume resuscitation. That will be the key to treatment. Make sure they are receiving antimicrobial prophylaxis appropriate for the surgery they're having. And these patients should be admitted to ICU following the surgery. Again, familiarize yourself with this treatment algorithm. Another type of infection is our GI infections. To begin with, C. diff is an anaerobic gram-positive spore-forming bacteria that has been identified as a major cause of antibiotic-associated diarrhea and pseudomembranous colitis. It's a very hardy organism, and it is the most common cause of diarrhea in the healthcare setting and results in increased hospital stays and higher mortality and morbidity among patients. This bacteria produces two principal toxins, and that's toxin A and toxin B. Toxin B is approximately 1,000 times more cytotoxic than A. And what the A does is activate macrophages and mast cells, and activation of these cells actually produce pro-inflammatory mediators. Toxin A is also an enterotoxin in that it loosens the tight junctions between the epithelial cells that line the colon, which helps toxin B enter to the epithelial cells. The signs and symptoms associated with this disorder are abdominal pain and diarrhea. Risk factors for C. diff include advanced age, underlying diseases, if they're having a GI surgery, presence of an NG tube, which gives us increased risk for transmission, the use of anti-ulcer medications, admission to the ICU, long duration of hospital stay, long duration of antibiotic administration, and the risk for this doubles after 3 days, use of multiple antibiotics, being immunocompromised, again sharing a hospital room with a patient who is C. diff infected. Treatment includes fluid and electrolyte replacement therapy. If possible, withdrawal of the antibiotic therapy and then targeted therapy to get rid of the C. diff, which includes oral metronidazole 400 milligrams 3 times daily, or vancomycin 125 milligrams 4 times daily. Additional therapies could include the use of probiotics, and these can help to restore our normal flora. This C. diff is common cause of mortality and morbidity, especially in our elderly, debilitated, and immunocompromised patients. C. diff that is non-responsive to conventional therapy may require surgical intervention. And some of these major surgeries, again, should be deferred if the patient is hemodynamically unstable, but some of these procedures can be temporizing interventions. When you take a patient back, they're at high risk for mortality. They are seen as very hemodynamically unstable. And again, this instability is likely during anesthesia. It's important to have invasive monitoring, including intra-arterial catheter, central venous catheter, and these may help you to guide your fluid administration as well as the use of your inotropes and vasopressors. Dehydration, acid-base abnormalities, and electrolyte imbalances can occur because of the diarrhea. Again, opioids can decrease intestinal motility and can actually exacerbate this condition. These The surgery should be done at the end of the day as to not expose others to C. diff. One of the most important things to do is prevent it, to prevent the spread. These spores are hardy and not destroyed by alcohol, so it's important to keep strict isolation and routine use of disposable gloves. Gown is important, and vigorous hand washing to remove spores. Also, remember stethoscopes, neckties, those are very potential repositories for the spores. Some cutaneous infection. We have necrotizing soft tissue infection, and it's a non-specific term that can encompass the diagnosis of gastric gangrene, severe cellulitis, as well as the flesh-eating infections. One of the most important aspects of these infections is that the severity may be underappreciated at the time of presentation. And the responsible organisms can be very highly virulent, and the course can go very quickly, and mortality can be up to 75%. The signs and symptoms of cutaneous infections include patients with features of generalized infection, including malaise, fever, sweating, and altered mental status. Pain can be out of proportion with the physical signs, and the cutaneous signs can be very mild and do not reflect the extent of the tissue necrosis, because necrosing skin infections can begin very deep within the tissue plane, so it's not seen superficially. Hypotension is an ominous sign and may show that the patient has progressed to septic shock. The resolution of pain also can be ominous in that it may show the progression to gangrene. The diagnosis is history is important. Our older patients and patients with history of alcohol use, malnutrition, obesity, trauma, cancers, burns, vascular disease, and diabetes are more susceptible, as are those who are immunosuppressed or those who are immunocompromised. There may be a high white count. There may be thrombocytopenia, coagulopathies, electrolyte abnormalities, acidosis, hyperglycemia, as well as elevations in inflammatory markers. Ultrasound, CT, and MRI may help you to diagnose the extent of the tissue necrosis. And blood, urine, and tissue samples may be sent for culture. Treatment would be a debridement of the necrotic tissue with the use of antimicrobial therapy as well. Broad spectrum coverage would be provided initially, and then as soon as possible switch to a more targeted therapy once the culture results are in. The prognosis again is associated with high mortality. If the patients survive initially, they may be vulnerable to secondary infections, and they may have to have repeat anesthesia for skin debridement, skin graft, as well as reconstructive surgeries. Preoperatively, the anesthesia provider should treat the patients as though they have severe sepsis. Again, resuscitate with goal-directed therapy. Remember, refer to that sepsis algorithm. Want to make sure you include administration of IV fluids and optimize the global oxygen delivery. With success should be reflected by a resolution of lactic acidosis and an increase in your mixed venous oxygen saturation. It is important to know debridement should not be postponed, because the delay in this can actually increase mortality. Intraoperatively, concern has been raised about the use of etomidate. Again, remember, we worry about that in any patients because it can result in adrenal insufficiency, which could actually be worsened by just one dose of etomidate. And know these patients are at high risk for major fluid shifts. increased blood loss and release of cytokines. So you need to make sure you have a good IV. Make sure that you have invasive intraarterial and CVP monitoring, and that can help to provide you some information. Blood should be cross-matched and readily available, and patients are at risk for both hypovolemic and septic shock. Post-operatively, the patient should be admitted to ICU, and antibiotic therapy and fluid resuscitation should be continued in the post-operative period. Respiratory infections, one of the common, when we think about respiratory infections, we think about pneumonia. Streptococcus pneumonia is by far the most common bacterial infection in adults. It also causes typical pneumonia symptoms. We can also have other types of pathogens that cause atypical pneumonia, such as influenza, Mycoplasma pneumoniae, chlamydia, Legionella, adenovirus. And they call them atypical because these are not commonly associated with pneumonia-producing bacteria, and they do not respond to our common antibiotics and can cause some uncommon symptoms. Remember, aspiration pneumonia is something we worry about, especially if somebody has depressed level of consciousness. Remember, alcohol, drug-induced alterations in levels of consciousness, head trauma, seizures, and other neurological disorders can lead to aspiration pneumonia. Also, patients with issues with esophageal motility, those with placement of NG tubes, esophageal cancer, bowel obstruction are also prone to aspiration. Also, poor oral care and periodontal disease. Again, induction and recovery from anesthesia also place our patients at risk for aspiration. And the clinical manifestation of pulmonary aspiration depend on the nature and the volume that is aspirated. So those who develop aspirate large volumes of acidic gastric fluids produce a pretty fulminant pneumonia and arterial hypoxemia. And then, aspiration of particulate material may also result in airway obstruction, and smaller particles can cause atelectasis. Post-operative pneumonia occurs about 20% of patients who undergo major thoracic and esophageal or upper abdominal surgeries. Chronic lung disease increases this risk as well. Other risk factors include obesity, an age older than 70 years of age, and operations lasting longer than 2 hours. Lung abscesses are also a particular problem that may develop after a bacterial infection. Those at highest risk are those who abuse alcohol and have poor dental hygiene. Also, septic pulmonary embolization, which again is common with our IV drug users because they have particles that can actually go into the heart. It can go and cause visitations on the tricuspid valve. Those can actually, those little pulmonary embolizations from that can actually form lung abscesses. The signs and symptoms, the finding of an air fluid level on chest x-ray can signify rupture of an abscess. Also, the patient may experience very foul smelling sputum. Antibiotics are the mainstay of treatment. However, in some cases, surgical drainage may be necessary, especially if they have chronic empyema. The diagnosis of pneumonia is based on some of the signs and symptoms. So initially the patient may have a chill followed by a sudden onset of fever. If it is a bacterial pneumonia, they can have copious sputum. They can also have other symptoms of pneumonia such as dyspnea, fatigue. A non-productive cough, however, would be indicative of an atypical pneumonia. Also, you may want to get a detailed history because hotels and hot tubs are associated with Legionnaire's disease. Also, fungal pneumonias are prevalent in those who have been cave exploring, and chlamydia can be following contact with birds. Alcoholism obviously increases the risk of an aspiration pneumonia or someone who may have decreased LOC due to substance abuse as well. The chest x-ray may show a diffuse infiltrates, which are suggestive of a atypical pneumonia, whereas if there's lobar opacities, that's suggestive of a more typical pneumonia. Atypical pneumonias occur more commonly in young adults, and again, radiography is useful for detecting any pleural effusions or different multi-lobar involvement. Labs you may want, you would expect elevation in the white count. You may also expect a decrease in the arterial oxygen content, and these may be severe, especially in bacterial pneumonia. They will also have a sputum sent for CNS, and this will help you guide the treatment, the antibiotic treatment. The treatment again would be empirical therapy initially until you have determined the actual cause, or which is the causative agent, and also looking for local patterns of antibiotic resistance should be considered as well. A mnemonic to help you remember what signs and symptoms, what physical symptoms you should see versus what laboratory findings you should see in respiratory infections. You can see the mnemonic TRASH, and I won't read those to you, but please be familiar. And then also the laboratory and other tests that should be, that you may see. Ventilator associated pneumonias again are the most common and can involve more. Diagnosis of ventilator-associated pneumonia can be difficult to differentiate from other causes of respiratory failure, again, such as ARDS and pulmonary edema. It's suspected if a patient develops new or progressive infiltrates on a chest x-ray with leukocytosis as well as purulent tracheal bronchial secretions. There is also a scoring system that provides a score that would be consistent with the diagnostic criteria. and that is shown on the next slide. It is an algorithmic score based on the presence of certain features. Just know that a score of greater than 6 is consistent with diagnosis of ventilator-associated pneumonia. I do not want you to waste your time memorizing the scoring system. Be familiar with what are on the scoring, what parameters are on, but not to memorize the specific scoring details for each. Again, this is that table that shows you those parameters. Be familiar with those, but again, I'm not concerned with you memorizing the scoring system. The treatment of ventilator-associated pneumonias includes supportive care for the respiratory failure, and again, appropriate antibiotics against the pathogen. Treatment should be, again, can be broad spectrum at first, and it should also be those who, which would cover Pseudomonas as well as Staphylococcus aureus, which are the most common pathogens that cause ventilator-associated pneumonias. But treatment should be narrowed to the targeted specific organism once culture and sensitivity are available, and it should be stopped at 48 hours if the culture's results are negative. Tracheostomy is not an emergency procedure, and it would be ill-advised to proceed when the patient has minimal pulmonary reserve. So this shouldn't be something you would worry about sedation for. If they do insist on tracheostomy, those can be done at bedside. Again, defer major surgeries until resolution or improvement of the respiratory infection. Other respiratory infections, such as severe acute respiratory syndrome and influenza. There have been influenza pandemics throughout history. In 2009, the big pandemic that came through was the H1N1. And it had, still has impacts on society today. We also have influenza A virus and the virus that causes severe acute respiratory syndrome, or SARS, are examples of virus that can run that are very virulent and can have high mortality rates. There's also bird flu, which is a subtype of influenza A. The bad thing about this, it mutates at a highly alarming rate. It can be passed from bird to human. Many cases were young children. The virus has not actually developed a high affinity for the human respiratory tract receptors. Therefore, human-to-human transmission is not a sustained event, and cases only occur in very small clusters. Again, this is showing the transmission of the H5N1 flu subtype A, and it shows that it can be transmitted from bird to human, but currently transmission can occur from person to person, but it's not sustained. So again, it only appears in small clusters of the population. The signs and symptoms of respiratory infections, again, are viral infection complaints, such as those non-specific things such as cough, sore throat, headache, diarrheas, arthralgias, and muscle pain. In severe cases, the patient can have respiratory distress. Also, the chest x-ray may show patchy infiltrates, areas of opacity, pneumothoraces, or pulmonary effusion. These viruses also can bind to the lower respiratory tract and create hemorrhagic bronchitis as well as pneumonia as with diffuse alveolar damage and destruction. And complications can include multi-system organ failure as well as severe sepsis. The diagnosis is based on history and context of the outbreak and detection of the virus and the sputum of the human. The treatment now are our antiviral drugs. And these drugs may decrease the severity of the infection. The prognosis, again, is based on the virulence of the virus as well as the patient susceptibility. If you're providing anesthesia for these patients, it's important to recognize the potential lethality of the infection. You want to maintain strict isolation precautions. Again, the patient and family should be counseled on the high risk associated, especially with SARS. Remember, primary transmission can be through direct and indirect respiratory droplet spread, and these viruses are very highly contagious. You want them in a negative pressure room. When you're caring for them, you should wear a full body disposable oversuit over your clothes. You should double glove. You should wear goggles and a powered air purifying respirator. If that is not available, you can use the N95 mask. Remember, anytime you're providing any type of airway procedure, that could be you're bagging the patient, suctioning the patient, all those things, you can actually aerosolize particles. So it's important to be aware of that. Also, if you require mechanical ventilation, you want to protect the lung, and so you need to provide protective ventilation, and that should be as expected to limit your tidal volumes to 6 to 8 mLs per kilo of lean body mass, and also to keep your airway pressure less than 30 centimeters water. Another topic that we as nurses have covered pretty frequently is tuberculosis. And remember, tuberculosis is a mycobacterium. Survives and thrives in tissues with high oxygen concentration. Again, which is why most of the time we'll have presentation in the apices of the lungs. We unfortunately have had the development of multi-drug resistant strains, and these have become resistant to most of our first-line treatments for TB. Most cases in the United States are from foreign-born individuals, IV drug users, as well as those with HIV or AIDS. It is estimated that 90% of patients infected never become symptomatic and are only identified through conversion through the skin test or through some sort of interferon release assay. Diagnosis, again, even though some are asymptomatic, the clinical symptoms would be the same things we ask our patients when they're admitted to the hospital. Have they had any recent weight loss, chest pain, bloody sputum, night sweats, or have they had a positive skin test, and as well as the most common skin test is the tuberculin skin test. The skin test should be read in 48 to 72 hours, and a positive reaction would be defined as a induration of more than 10 millimeters. Again, if the patient's severely immunocompromised, then it would be considered positive if the reaction was of 5 millimeters or more. Chest x-rays are important for the diagnosis. What you would see is subapical or apical infiltrates. Those are very suggestive of TB. Again, patients with AIDS may demonstrate a less classic picture. And people who are at risk, again, would be our healthcare workers, which is why we need to be checked for TB. The actual the diagnosis again would be based on sputum smears, and a positive smear is the definitive diagnosis. The good news for TB, for those with susceptible strains, the majority of patients who receive adequate treatment will be have experienced negative sputum smears within 3 months of treatment. The current treatment for those susceptible are isoniazid and rifampicin. The treatment again depends on where the TB is located. Those with pulmonary TB primarily can receive treatment for 6 months, and that seems effective. Those with extrapulmonary TB could require a longer course. With anesthesia, you want to do a detailed history, and we should include question them about the persistence of cough, the TB test status, and again, patients with HIV or AIDS should undergo a thorough review of systems, again, to elicit this possible history. Remember, elective procedures should be postponed until they're no longer considered infectious. If we have an emergency procedure, it is important to limit the number of personnel involved. Only those needed, it should be in a negative pressure environment. Patients should be transported to the operating room wearing an N95 mask, and this should prevent exposure to others, and the staff should also wear it. There should be a high efficiency particulate air filter should be placed on the anesthesia delivery circuit between the Y connector and the mask. Should also the mask, the laryngeal mask airway, and the tracheal tube. Bacterial filter should also be placed on the exhalation limb, and this decreases the discharge of this bacterium into the air. And remember, anesthesia equipment should be sterilized with standard methods using a disinfectant that would destroy TB. And use of a dedicated anesthesia machine and a ventilator for this type of patient is recommended. HIV and AIDS, again, until about 1981, we did not realize what caused HIV or AIDS. All that was really known is that this disorder produced with unusual malignancies as well as opportunistic infections. In 1984, the cause was found, and it was found to be a retrovirus, which was named human immunodeficiency virus, or HIV, type 1 and type 2. It is currently estimated that about 50 million people are infected worldwide, and 1.2 million in the United States have AIDS or HIV. The good news, there are only 4 types of fluids that can transmit HIV, and that is breast milk, blood, vaginal fluid, and semen. You cannot get it through saliva, you cannot get it through urine, and you cannot get it through sweat. So only the 4 fluids I mentioned. It can be spread through sexual intercourse. It can be spread through IV drug use. It can be spread through pregnancy from mother to child. and it can also be transmitted through blood transfusion. We have the antiviral therapy, and it has decreased the rate of the disease progression. Again, currently no cure is available, but the United States, as well as other places, are still researching for the development of vaccines to help prevent the transmission of the HIV virus. The signs and symptoms of HIV, what you generally see is that you will have an acute seroconversion, which can occur after 2 to 3 weeks after inoculation with the virus. And this can occur with just general transmission. If the transmission is from sexual contact, it may take anywhere from 6 to 14 months for the seroconversion to occur. So basically, you can have transmission of the disease even when there is no antibodies detected in the blood. Because what you have initially is the virus will invade and it will begin rapid replication. And during this period of time, the patient may experience those signs and symptoms that are associated with a flu-like illness. Within 1 to 2 weeks, again, rapid replication of the virus is occurring. And after several months, this will gradually decrease. The viralemia will decrease, and you will basically see a balance between the production of the virus as well as the destruction of the virus, so you'll have a steady state. Generalized enlargements of the lymph nodes is the hallmark of HIV infection and may persist until they are on antiviral therapy. And HIV positive patients are not considered to have AIDS unless they have one of the AIDS defining diagnosis present. So when we talk about it being a retrovirus, what do we mean? And a retrovirus is a single-stranded RNA virus that stores in its nucleic acid in the form of mRNA, and it targets the host as a parasite. Once it's inside the host cell, it uses reverse transcriptase to produce DNA from its RNA, and the new DNA becomes incorporated into the host DNA. And so the host basically treats the DNA as its own and begins to replicate the virus as it replicates itself. Again, characteristic of retrovirus is they're cell damaging with a long latency period and a chronic course of infection. The diagnosis of HIV, the standard diagnosis is through an enzyme-linked immunosorbent assay, the ELISA test, the results of which become positive when antibodies to HIV are present, and this can normally occur in 4 to 8 weeks after infection. The test is not a measurement of the viral load, it just indicates the presence of antibodies to HIV. During the initial period of infection, there is significant viral load and the patient is highly infectious, again, even before those antibodies may become present. Therefore, a false negative test can result. Once they have a positive diagnosis that HIV is present, this becomes confirmed with a Western blot test or a direct measurement of the HIV viral load. Again, the viral load can be measured with a polymerase chain reaction RNA analysis. The measurement of the CD4 cells to assess the degree of HIV progression. Because the HIV is a lymphotrophic and has a particular affinity for CD4 cells, measurement of these cells will help to determine the degree of HIV progression. The CD cells are measured And 98% of the helper T lymphocytes are located on the lymph nodes, which is a major site for viral replication and T cell destruction. So during the acute infectious phase, the CD4 count will decline dramatically, then rise again. Over the course of 8 to 12 years, there's a slow decrease in the CD4 counts, then a gradual involution of the lymph nodes with a slower decrease in the CD4 cell counts. And this would be accompanied by an increase in the viral load as the onset of AIDS can then occur. The primary targets of HIV are the CD4 cells, the macrophages, as well as the natural killer cells. This slide is showing what we were just talking about, that initially after the patient is inoculated with the virus, there's a period of a rapid replication of the virus, so you'll see a rapid increase in the viral load. During this period of time is when you would have your major viral type symptoms. Then you start going into that steady state of replication and destruction, and this can result in a clinical latency period where you either don't have any symptoms, or if you have symptoms, that can just be simple swelling or enlargements of lymph nodes. Again, as this disease advances, you can see symptoms of the AIDS actually developing, and when you see this, you'll start seeing the decrease in your CD4 counts again and an increase in your viral load. After diagnosis is confirmed, it's important that the patient undergo further testing to determine the viral genotype and phenotype. In addition, HIV sensitivity and resistant to the antiviral therapy is determined, and the goal is to minimize resistance to treatment by tailoring that to the individual. Again, patients can, even if they have AIDS, they can have different genotypes, different phenotypes, so it's important that even those patients who both have the HIV virus, they still use and are educated in the use of protection if they are sexually active. Once the patient becomes HIV positive, there is a long period of that the patient will typically be asymptomatic with no external evidence of immunosuppression. However, this can eventually progress to AIDS with the associated opportunistic infections and ultimately death. This continuum can be interrupted, delayed by the instituting of what they call HAART therapy, or it's also known as highly active antiretroviral therapy, HAART, and that is where there is a combination of antiretroviral drugs that are used to attack the virus from different physiological standpoints. The HIV virus has a very high affinity for the myocardium, and as a result of this, we may see left ventricular dilation, and we also may see cardiac dysfunction that can occur from this. Also, a small percentage of HIV or AIDS patients will present with pulmonary hypertension. This is about 1% of patients. Cardiac disease may also be exacerbated by the antiretroviral therapy the patients are on. Also, patients may exhibit some abnormal echocardiogram findings. The central and peripheral nervous system manifestations. The peripheral neuropathy is the most common neurological complication seen with HIV positive patients. Those with AIDS can show evidence of polyneuropathies or myopathies. Also, autonomic nervous system dysfunction can be present. The central nervous system, you may see dementia. You may also see infectious as well as neoplastic involvement. And there are three diagnoses that comprise the majority of predominantly focal cerebral diseases. And this is your cerebral toxoplasmosis, your primary central nervous system lymphoma, and progressive multifocal leukoencephalopathy. The pulmonary manifestations of HIV positive patients is usually caused by the opportunistic infections. Complications can include respiratory failure, pneumothoraces, and chronic pulmonary disease. There's also cavitary lung diseases that can be present, and that can be due to lung abscesses, pulmonary TB, as well as fungal infections. HIV itself can also directly be toxic to the lung tissue, and so it can directly affect it and may cause destruction, a destructive pulmonary syndrome that's similar to what we see in emphysema. We also may see a Kaposi sarcoma, and PCP, which was formerly known as pneumocystis carni pneumonia. We can see that in patients, but it usually doesn't occur until your CD4 counts fall below 200, and has become a lot less common with our current antiretroviral therapies. With this, what you see is the chest x-ray can be normal, but will typically show bilateral ground glass opacities, and pneumothoraces may be evident, or there may be a reduction in your lung function test with your PFTs. Endocrine issues, we can see adrenal insufficiency present in this patient population. Also, some of the medication can result in issues that we can see, such as glucose intolerance, change in lipid metabolism, as well as fat redistribution. Some of the hematological effects, the most common early finding of HIV is anemia. We may also see lymphocytosis with a main increase in the CD8 T cells, which can appear within 2 weeks of the initial HIV infection. We can also see thrombocytopenia, which typically will worsen as we decrease our CD4 counts, especially those less than 250. HIV positive patients are also more prone to hypercoagulable states and coagulation abnormalities. And we also can see renal issues, especially with those patients on our retroviral therapies. The treatment is the high active antiretroviral therapy, and what this targets the various steps in HIV replication cycle. There are 6 major classes of medications that can be used, and non-adherence to the treatment plan is one of the main causes for the development of viral resistance and treatment failures. Patients who do develop resistance or advanced AIDS may require 4 agents as well as some booster agents. Recommendations are that therapy be started when the CD4 counts begin to decrease and approach 500. This slide shows you the life cycle of the HIV virus, as well as some of the commonly used medications and where they would actually target the be targeted by the antiretroviral therapy. Again, some of the common drugs used, and you can see some of the interactions that are present with those. Also, you can see anesthesia-specific drug interactions. Very important for us to know, since we may provide anesthesia for these patients. And again, Adverse reactions can be life-threatening and potentially fatal. Again, the treatment typical regimen would include 3 antiviral drugs based on the sensitivity, the resistance patterns, the co-receptor subtypes, as well as the virulence subtypes. The aim in therapy would be to have an undetectable viral load in 24 weeks of therapy, as well as improving the patient's life and extending the length of their life as well. There is unfortunately a condition called IRIS, which is immune reconstitution inflammatory syndrome. When patients begin this antiviral therapy, they can develop this syndrome, and it's a result of the restoration of their immune competence. And this can lead to a deterioration in their clinical symptoms in the context of them actually having an improvement in their CD4 counts and a reduction in their viral load. During this time, they can have appearance or increase in the severity of a previously silent clinical disease such as hepatitis A, B, or C, PCP, TB, or other dormant infections. Anesthesia-related issues. Unfortunately, there's little information on the surgical risk of HIV patients. HIV, again, if you have an HIV patient, you would classify them as an ASA2 if that's the only disorder they have. If they have AIDS, they could be classified a 3 or 4 depending on the severity of the coexisting diseases, as well as the presence of related and unrelated conditions. Again, you would want to obtain a thorough history. Currently, there isn't really any specific utility of obtaining a CD4 count and a viral load determination before surgery. Various studies have shown there's no significant difference in perioperative outcomes in those patients whose CDC counts are higher than 50, with outcomes of the patient populations without AIDS or HIV matched for the same surgical procedure, comorbidity, and ASA. Viral load is also not a predictor of perioperative outcomes as long as the viral load doesn't exceed 30,000 copies per ml. And there is currently no specific anesthesia technique that is recommended solely based on the presence of HIV or AIDS. It is important to look at the coexisting diseases as well as the manifestations of HIV in these patients. Remember, we would classify it as AIDS if the patient's counts become less than 200 or they have the presence of 1 or more opportunistic infections. And if they have the presence of 1 or more opportunistic infections, they would be diagnosed as AIDS even without an increase in those CD4 counts. The information for this lecture has come from your Stolting chapter as well as UpToDate.com and the CDC.